Hi, it's Aaron Sutcliffe here for my presentation for EHR523 Exercise Intervention for Breast Cancer Patients. The case study I have is a 40-year-old female who on self-examination felt a lump in her right breast. As a result, she went for a mammogram, which also revealed a lump in her right breast. As a result, there was a core needle biopsy undertaken by the surgeon and an axillary clearance, along with some MRI scans that were performed, and unfortunately it confirmed a T3NA2 MO invasive ductal carcinoma with an estrogen positive, which was estrogen positive, but negative to HER2 receptor. What was confirmed through the test was that the tumour was 6 centimetres across, the cancer had spread to 7 lymph nodes, but fortunately the MRI confirmed it had not spread anywhere else. So it was referred to the surgeon who recommended that the right breast be removed through the process of a mastectomy, as well as lymph nodes being removed. So the patient then underwent a total mastectomy surgery and the removal of lymph nodes, but at the time the patient didn't want a breast reconstructive surgery, so it wasn't considered. So in consultation with the radiation and medical oncologist, they agreed to provide external beam radiation for 6 weeks after the surgery, which research has shown has been effective in reducing the size of the tumour or killing potentially precancerous cells. In adjunct with the adjunct therapy to the radiation was chemotherapy. The chemotherapy type used was Taxol. The properties of Taxol are used to stop cancer cells from dividing. They're a mitotic inhibitor. The chemotherapy process was a bi-weekly one, treatment for 3 months. Again, adjunct to the 6-week radiation therapy. Hormone therapy wasn't used at this stage of the treatment because of the likely increase in probability of breast and lung fibrosis, which chemotherapy and radiation already provide an increased probability of that anyway. So the surgeon didn't want to increase that any further by providing any further drugs. The side effects were for the radiation were the red skin, a bit of localised pain, and fatigue. On top of that, the chemotherapy caused hair loss, infrequent vomiting, diarrhea, and some brain fog. As a consequence of the change in features with hair loss and feeling ill, the patient also started to suffer from depression. The comorbidities were that she had mild asthma, but this was diagnosed when she was younger, and she very infrequently ever used a Ventolin inhaler. Instead, she did carry it with her, but that was something that she didn't really ever have to bother about much. However, as discussed, she has now been diagnosed with depression. The exercise history for the patient is regular normal daily activities that include gardening and walking around the house, sometimes walking the dog, but mostly she was sedentary because of her clerical position in the bank. The risk assessment used was the ESSA pre-screening activity tool. On the assessment of that, there was confirmed that she was a low to moderate risk. She had no other comorbidities, and that her health other than the cancer was relatively stable, and she didn't have anything else wrong with her, so there was no reason as to why that she couldn't complete aerobic and resistance training exercises. The initial consultation was included previous medical histories, medication, recent surgeries, which was the right breast mastectomy, Also confirmed that she wasn't a smoker or a drinker, and that she had no prior high cholesterol or high blood pressure. Again, there were no musculoskeletal injuries that were recent in nature, so therefore there was no reason as to why she couldn't undertake aerobic and resistance training. The team care arrangement organised by the general practitioner provided to the exercise physiologist included medical history background, a lifestyle history of whether she smoked or consumed alcohol, provided with blood biochemistry results, which all came up to be fine and within the normal parameters. Also included her anthropometric height and weight, so forth, which all came in okay. So the team care arrangement provided to the AEP and the other allied health professionals that had been recommended to the patient included patient education in regards to treatment strategies and potential future treatment strategies. Also for patient education on what they could do to help themselves. Also provided a GP and oncology nurse that would go around to her house in the early stages after being diagnosed and receiving surgery to help her out. Also, the GP has recommended a psychologist be appointed to speak with the patient in regards to her depression, and the GP would prefer her to try that course of action rather than taking antidepressive drugs. Also notes that there's normal blood chemistry at this point in time, but that is something that needs to be checked. Also confirming that there's normal blood pressure, which needs to be checked regularly too when she comes to visit the GP. Now the GP's confirmed that there's been a medication review and that everything's stable at this point in time. The GP's also recommended a dietitian to confirm with and help the patient with dietary intake, and the AEP has been incorporated into the management plan to increase the physical activity of the patient. Now, as stated, the GP and the oncologist are there to provide education on the treatment plan, patient education provided by the GP and visiting oncology nurse, and strategies provided by the psychologist on how to reduce anxiety and depression, which research has shown can be just as effective in many cases as drug therapy. Now, the team care arrangement, as stated, provides information regarding the regular blood test to confirm correct biochemistry to ensure the safety of drug therapy for the treatment of the cancer. GP and oncologists are there to provide correct dosages as required for radiation and chemotherapy to ensure effectiveness and reduce side effects. The dietitian's there to review the diet, which may need to be altered depending on medications, and the AEP is there to consult with the GP and oncologist for a physical activity program. Okay, so the exercise testing undertaken was a 6-minute walk test used to assess the aerobic fitness. There was a 30-second sit to stand there to measure muscle endurance. Alternatively, there could be a 10 rep max leg press. It was also incorporated was a 10 rep max dumbbell bicep curl to measure upper limb strength, and why the dumbbells were used was to confirm whether there was any disparity between the right arm, which had some lymph nodes removed, compared to the left arm. Also, there was a sit and reach test there for flexibility, and also a shoulder flexion test was undertaken with the use of a goniometer, again to compare the difference between the right hand side that had been operated on and the left hand shoulder. There was also a 30-second timed up and go test for functional movement balance, and confirmed with the patient that if she felt any chest pain or heart palpitations or felt ill or anything whilst training, that the test would stop immediately for safety concerns. we didn't expect that would be the case because other than the cancer, she'd been quite healthy. The assessment protocols were that the 6-minute walk test was conducted indoors on a 20-metre track on a flat floor. 30-second sit to stand was conducted with the chair against the wall, so there'd be no slippage, and all instructions were provided. The sit and reach test was undertaken to measure flexibility, and the timed up and go test again was started from a seat, and it was to time how quickly the person could get up off the seat, walk around the marker 3 metres away and sit back down. The tests were performed as safe, reliable and valid, and provide baseline figures for reassessment to confirm whether the exercise program has been successful or not. The results of the assessments were the 6-minute walk test. The patient walked 542 metres. A 30-second sit to stand equaled 14. The sit and reach was 29 centimetres, and the timed up and go was 7.5 seconds. The goals were to improve cardiorespiratory fitness, to improve strength, balance and flexibility, and overall health. It was also there to make her feel better about herself, provide more energy to complete normal daily tasks, and also to improve her mood and positivity. The benefits of exercise for breast cancer patients are the prevention of body weight and the improvement of mood. The body weight is very important. Excess adipose tissue can cause decreases in oxidative stress and decreases in estrogen, as well as increases in inflammatory responses, which are all counterproductive to fighting cancer. Aerobic and resistance training reduces insulin levels, but increases insulin growth factors, which can have a detrimental effect on, which has a detrimental effect on cancer and can cause it to tumours to grow. The ACSM recommends 150 minutes of moderate exercise, aerobic exercise a week, or 75 minutes of intense exercise, strength sessions 2 to 3 a week, and also flexibility training incorporated. The first 4 weeks of the exercise program utilised aerobic training and strength training. The FIT principle was incorporated into the program to ensure to make use of frequency and intensity and time and duration, so forth. The days were broken up where there'd be training in the clinic and there'd be training also at home. The patient was also encouraged to train outside of home as well. The last 4 weeks there was a progressive increase in duration in time where the patient utilised the aerobic exercise either on the treadmill or on the bike. Regarding strength training, there was increases in loads and increases in number of sets as well. There was also the addition of a few extra exercises, including standing calf raises and so forth. Again, even the home training program was increased to increase TheraBand colour from red to green, to increase intensity and load. Also, there was an extra day added on for the Saturday, and the patient was encouraged to do a little bit every single day. The results of the exercise program were very encouraging. After 8 weeks of the exercise program, the patient improved their 6-minute walk distance to 630 metres. The 30-second sit to stand increased to 22, the sit and reach to 35 centimetres, and the timed up and go to 6.5 seconds. Importantly, the patient reported that her mood had improved, and this was reflected by a much better quality of life questionnaire that she completed as well. On top of this, the GP and oncologist were very happy with the progress, and the blood results confirmed that as well. So all was looking good for the patient. Here's a copy of the reference list that has been used in compiling the presentation and to validate the contents of the presentation.